Good morning. I think after fitting and selling the spectacle, actually you have to face this problem also. I don't have any financial interest, but I have taken some help from this eyes and SLR lenses for this thing. It is the biggest insult for a doctor or a practitioner is after selling the or giving the prescription, patient comes and tells you that my earlier spectacles was better. This is not that good. So you have to be careful about that aspect. So with the use of more and more progressive lenses, actually these type of comments are increasing. There are many causes of non-tolerance of spectacles. You see the refraction, dispensing and communication. You see that a major portion is about communication. Actually you have to be very clean in this aspect. Around 60%, one study shows that 60% of the patients are unhappy due to many reasons. Could be due to a heavy frames and lenses, or a near vision correction is either too high or too low. Frames are not fitting, or some allergy to the frames, then fogging of the lenses. There will be some problem with the strain with the use of the glasses. There could be distorted lens images, there could be skin cushion distortion, upward head positions required to read, double vision sometimes happens. So all this aspect we have to think about how to prevent it. So it's very important, even if you are not taking a regular history in occupation about another condition, but you have to be very careful in taking the occupational history here. And careful refraction, either by you or your refractionist, to do it very carefully. If necessary, you have to go for this ecloplegic refraction. End of the refraction, this is a must. You should ask the patient, if he is wearing a glass, you should ask whether the present glass or what you are going to give the refraction is better. And you have to discuss with the patient what are all the requirements the patient is requiring. If you have a wrong prescription, there could be a overcorrection. Some occupations, you know that like carpenters or priests, there occurs undercorrection hernia, inadequate correction in case of cylinders. Then your prescription, if you are writing it, you have to be very careful in writing minus decimals and all that things. And measurements, as Dr. Andrews has mentioned earlier, the measurements are very important. You should see that frames are fitting. You can use the computerized selection, or you can personally do it. Then IPD is very important. This will help you in avoiding lot of intolerance. IPD measurement can be with the optician's ruler or any electronic devices available by different companies. The distance between the inner canthus of one to the outer canthus of the other eye, that is a binocular IPD. Distance between the nasal border of one to the nasal border of the other. So this is way you measure it. And frames must be comfortable. You should ask the patient to wear the frames and ask the patient very specifically whether it is comfortable. And not only ask the patient, you have to see the optician should see whether it is comfortable or it is tight or it is very loose. Lens should be perpendicular to the visual axis and middle size should be accurate. Metal frames with the nose pad may tilt. So this is one disadvantage, but sometimes it is an advantage in case of progressive lenses. Frames should not rest on the apple of the cheek. Actually, should not cover the eyebrows also, you know that. Round frames in astigmatism. Some of the people, there was a period when people were selecting round frames and this can rotate inside the frames. Vertex distance is very important in high errors, especially in high myopia and high hypermetropia. Lenses, try to fit the lenses in the anterior focal point, should be large enough to give good visual fields. And also you have to see that the trial frame vertex distance as well as your frame, the actual frame vertex distance is equal, otherwise the refraction will change. High index lenses, this is very important because this is going to make a lot of difference. So you can use a high refractive index lenses also for to correct this. Anti-reflection coatings will make the patient comfortable, so that that reduces the patient's complaints. finding the optical centers, he can use a lensometer or any manual methods. When we are still, many of the patients are using the regular bifocals, the cryptop or executive or D bifocal as well as varifocal. The image jump is a big problem with the bifocals. Most of the time when they start using, they will tell that I can't walk with the bifocal. You have to educate the patient and you have to check whether any error in fitting. And before we go into the progressive lenses, as Dr. Andrews has already shown that the different parts of the progressive lenses, and we have to see that this is a stable distant area and this is a stable near area. But in between is a narrow corridor, and this is the area where the patient feels a lot of discomfort. And also, actually the area, the blending region, where the cylindrical powers are added on the blending area, and that area will be distorted. Depends upon the company, the models, it can vary in that area. But this area, when your patients are using the first time the progressive lenses, they will go on complaining about this distortion here. So we have to decide who are the best candidates for the progressive lenses. The previous progressive lens wearers, they will accept it very well. The first time users, the highly motivated people, especially the people, ladies usually at the age of 40, they will accept it very well. And difficult people are high eye powers, previous wide segment bifocal wearers, they will always compare with the previous class and they will go on complaining about this. Individual sensitivity to vertigo or motion sickness, they will have initial problems and they won't adjust with the situation. And individual sensitivity to the changes in vision also, you have to be careful. When selecting the frame, you should not select it very narrow, very small frames. Even though people will tell that it's 20 mm, you can make it, and many of the time the patient will come back with the problems. And this everyone is aware, you have to be very, very careful about the bandoscopic tilt. Actually, this is a tilt of the lens bottom is rotated towards the cheeks. If it is coming in the opposite way, the retroscopic tilt, it is a real problem. There is actually bandoscopic tilt is a must because this will increase the near vision area and patient will be much comfortable with the bandoscopic tilt. Even if the frame is having this much of bandoscopic tilt, you have to see that that frame in different people will have different bandoscopic tilt because it depends upon the ear position. If the ear position is upper or lower, the bandoscopic tilt can vary. So you have to measure in every patient. So this is the effect which I was telling you earlier. Suppose it is in the straight area, then the lower field is reduced. If it is tilted downwards, then the field reading this area will be increased and patient will be more comfortable. So bandoscopic tilt, we can measure it. With different methods. I think one of the video is not working. Okay. Then we will come to the vertex distance. That's the distance between the back surface of the lens to the front surface of the cornea. So what we aim is actually the minimum vertex distance. With the minimum vertex distance, you will get the maximum field. But the only thing you have to look at is actually the eyelashes should not rub on the lenses. The vertex distance also can be measured with different tools, or you can use computerized different machines for that. Then the face form wrap, that is also is very important. The face form wrap is the inclination of the temporal edge of each lens towards the face. Otherwise, if this wrap is not there, the patient's peripheral field will be a problem. So this also you have to be very careful. And when the patient is coming back with the problems, you have to assess all these areas. This is a busy office system which Dr. Andrews was mentioning about. All the videos. Busy office system, you can have this system installed in your optical shop so that all the measurements will be taken automatically. And the patient will be very much impressed with this system so that you can sell in a higher lenses also. So Dr. Andrews again mentioned about symmetric lenses and asymmetric lenses, and also about the PD errors. Actually, if there is a little bit defect in the PD, then you see that the patient vision in this eye, actually in this eye, the patient vision, near vision will be in trouble, because it is PD, the center of the lens and the pupil is not coinciding there. If there is some residual cylindrical power is there, so that will be affecting the distant vision as well as all the near vision. So that this whole area in one eye, suppose this eye is having problem, the patient will have a lot of distortion. So you have to add whatever cylindrical correction is there. Don't neglect this cylindrical correction. Sometimes there will be some problem, patient want a lens immediately on the next day. Don't correct it that way. Then again you have to think, some of the patients they will go on telling that I was using progressive lenses and now you have prescribed another progressive lenses. I am used to progressive lenses, but now I am having problems. So you have to understand, what you have to understand is, say plus 1 is easier to adapt, and plus 3 or plus 2 that will be more difficult, because your blending zone will have more problems. Your temporal and nasal, except the central area, both zones will have more problems. So you have to tell the patient, once the power increases, the patient's problem also increases. It's not only the adaptation to earlier progressive lenses. This is also already mentioned, this is about the hard type design and the soft type design. And you have to really understand which patient you have to give a hard type design and which patient you have to give a soft type design. Hard type design, the central zone is very narrow, but one thing you have to concentrate is, if the patient is sitting and doing some works like a growth method, then sometimes he will be more comfortable with a hard type design. A soft type design, he will have problems. And this is another problem with the skew deviation. So correction of astigmatism also is very, very important. Then about the progressive lens troubleshooting, I am not going to all the details. Whenever the patient complains about a particular complaint, then you always have to verify your refraction, the prism, wanted as well as unwanted prisms, the height of the pupil, monocular, IPD also you have to change it. According to patient's complaints, you have to vary. If the distant vision is blurred, the patient is telling that my distant vision is blurred, you verify the refraction, verify the prescription, and if the patient is telling vision field is narrow, then again you have to see a set of checklist. So this will be easier to correct it. Most of the patients will be complaining about intermediate vision. So like Dr. Andrews said, you have to go for specific lenses for computer vision. Reading area is another problem, and all this thing you have to have a set of systems. Because of the lack of the time, I am not going into all the details, and every point you have to be very careful. So our responsibility is, do not change the refraction if the patient is not symptomatic. Patient is telling that I am comfortable with the glass, please don't change the glass. And also when you are changing, don't change the base cover. So proper counseling of the patient is very important. And those who are using for the first time, those who are shifting to bifocal or progressive lenses, and never assume a hostile attitude to his complaints. Most of the time patient will be complaining, he will be having some problem. So if you are not finding out, don't tell that there is no problem. There will be a problem. So you try to find out the problem. Thank you for your time.